the cue. We'll start slow. I'm going to talk for like 15 seconds. So just ramp up the speed and the noise until when I say the word, more resilient health systems, that's when we lose our minds a little bit again to remind the other rooms that we have gotten started. Is that okay? You can shout back. Is that okay? Yes. Fantastic. Oh, I hear that. Here we go. Ladies and gentlemen, for those of us joining online as well, this particular session is entitled Unlocking the Power of Digital Health Interventions, essentially understanding the key role of health policy and systems research. And the lady who's going to take us through it is Dr. Lorena Guerrero Torres, who is the Technical Officer, Alliance for Health Policy and Systems Research at WHO. Where she leads multi-country initiatives in public health agency reform and digital solutions for primary care management. She's a physician. We do one. She's a physician, a public health researcher, trained in Mexico, and at LSHTM. She works with governments to apply evidence for stronger, more resilient health systems. Ladies and gentlemen, put your hands together and welcome to the stage Dr. Lorena to take us through the session. Over to you, Dr.
Thank you so much. That was a wonderful introduction. I could get used to these. And thank you, everyone. Good morning, everyone, for being here. Habari za asubuhi. As I was introduced, I am Lorena Guerrero Torres. I work as a technical officer at the Alliance for Health Policy and Systems Research, and I want to welcome you to this session. And to kick us off, I will start with a video that our Executive Director of the Alliance for Health Policy and Systems Research, who unfortunately couldn't be here, sent to us. So please, if you can play the message from Dr. Kumaran Rasanathan now.
Good morning, everyone. Good morning, and thank you for joining us for this session on how health policy and systems research can help unlock the power of digital health interventions. It's a pleasure to be here, although only virtually, at the Global Digital Health Forum in Nairobi for this important discussion. Across all countries, digital health interventions are transforming health systems and how data is collected, how supplies are managed, and how services are delivered in primary care. Yet, despite this remarkable growth, too many digital solutions remain fragmented, short-lived, and insufficiently connected to the realities of the health systems they're meant to strengthen. We see systems that do not talk to each other, tools that are difficult for health workers to use, and innovations that don't sufficiently consider the governance, financing, and institutional support essential for the long-term success of health systems. These gaps limit the potential of digital health to improve equity, performance, and outcomes. We feel that this is precisely where health policy and systems research can make a crucial difference, helping to understand not only what works, but why, for whom, and under what conditions. Health policy and systems research brings attention to context, to institutions, to power dynamics, and importantly, to the lived experiences of health workers and communities. As such, health policy and systems research needs to be co-produced, not just by researchers, but with implementers, policymakers, and civil society. So today's session draws on a program that we've been proud to undertake on digital interventions for primary healthcare managers with the support and collaboration of the governments of Sweden and Norway and the Gates Foundation, as well as with our colleagues at the World Health Organization who lead on digital health. We had 10 research teams across 8 low and middle income countries. And I'm delighted that today we have colleagues from this program from Bhutan, Georgia, and Ghana who will discuss issues as varied for primary care and digital health as governance and integration, data privacy and quality, and how to overcome fragmentation and interoperability. I'm looking forward for a robust and stimulating discussion that shows not only how we can make the most of digital health interventions, but also how health policy and systems research can do so much more to ensure the systematization of digital health interventions, not just for greater efficiency, but also to improve health equity. Thank you.
Excellent. Thank you so much. Can we go back to the slides, please? Super. So before we hear from our panelists and our speakers from countries, I want to give you a brief introduction on who we are at the Alliance, what is health policy and systems research, and also talk a little bit more about this program of work. So to start with, the Alliance for Health Policy and Systems Research is a hosted partnership situated at WHO, at the Science Division. It was created in 1997. And we are a small secretariat sitting in Geneva, but we are also a big team of partners across countries. You will hear from some of our country researchers and partners from 3 countries in this session, but we also collaborate and engage with different partners from different countries. I see people from Beirut. We collaborate with people in Beirut, the American University of Beirut. We also have collaborations and partners in Ethiopia, EPHI, the Ministry of Health. So really, it's a big network that support and help us achieve our outcomes. And so our mission is to generate and support the generation and use of health policy and systems research to strengthen health systems and address health systems challenges. We have a new strategy since last year. We have 5 thematic areas. One of them is PHC for UHC. That's our traditional work. We have a lot of work there on financing, on modeling for strengthening health systems. We also have work on NCDs, on climate change, and also on emergencies. And one of these thematic areas is digital health, so applying a health systems focus to digital health and improving outcomes. We do this through 3 functions. One of them is to generate new and impactful knowledge to address national and subnational challenges. The second one is strengthening capacities and institutions to improve policy and implementation through research and learning. And the third one is advocating for new policy and systems research that can address global health challenges. Now, let me talk a little bit about health policy and systems research. You heard a little bit from our director, but really it's an applied field. It seeks to understand and improve how societies organize themselves in achieving collective health goals. It also tries to understand how different actors interact in the policy processes and in the implementation processes to contribute to policy outcomes. This is a field that pays special attention to the role of context, both in understanding the problem, but then also in developing solutions. And it also recognizes that health systems are complex and that these systems are shaped by incentives, power relationships, trust, institutional histories, and the everyday realities of the communities that are part of the health systems. And so this lens is really important for digital health, where the technical solution is not the only solution. We also see that adoption depends on institutions, on trust, on governance, and the capacity of systems to adapt to these transitions. So this is why we developed this program of work together in collaboration with the department at WHO on data, digital health, analytics, and AI. We developed this program with a goal not to evaluate digital health interventions in countries, but to really understand their interaction and their integration at the health system in different contexts. And we really wanted to understand the unintended consequences of this integration within these systems. And so, through an open call for proposals, we selected 10 research teams across 8 countries. You can see them here. We had teams in Bhutan, Ethiopia, Ghana, Georgia, India, Indonesia, Zimbabwe, and Pakistan. The projects were different. They were diverse. They were focusing on different types of digital health interventions. Some of them were immunization systems, as you can see. Others were registries, medical records and systems, also management information systems and decision support systems. And really, one of the requirements to participate in this project is to have a co-production along with implementers and policymakers. So as you will hear during this conversation and in the panel discussion, part of the research teams were people involved in the decision-making within the countries. And now, with that introduction, I would like to introduce our first speaker from Georgia, Dr. Tinatin Manjavitse. She's a researcher at the Department of Medical Statistics at the National Center for Disease Control and Public Health in Georgia. And she will share insights from the Georgian Birth Registry. Over to you, Tinatin.
Good morning, everyone. Should I just... Yeah. So today I'm going to present briefly the results we got from the research with the support from the Alliance of Health Policy and Systems Research. It's about evaluating the continuity of information for maternal care after the implementation of the Georgian Birth Registry. Just to start with, Georgia is an upper middle income country with a population of 3.7 million. It has a quite privatized healthcare sector and high doctor-to-population ratio and low doctor-to-nurse ratios. We have a universal health coverage which was implemented in 2013, and in general, digitalization of the healthcare system is one of the top priorities of the government. Right before the birth registry was implemented, the main challenges for the women to get healthcare services during pregnancy was the lack of data availability, especially between pregnancies. For the medical facilities, it was not available, and also the financial reimbursement process was very difficult because the women had to physically visit to the Ministry of Health to get a physical voucher for the financing of the pregnancy. So in 2016, with the support from the UNICEF and the Arctic University of Norway, Georgia implemented Georgian Birth Registry. So it's a mandatory by law to register all pregnancy and deliveries and newborn-related information in birth registry, and all antenatal care centers and maternity homes are obliged to do that. As you can see from this graph, the antenatal care attendance is quite high and stable. It's around 94 to 96% over the last 6 years. But still we have 5 to 6% of women who never attend antenatal care. But the hospital-based deliveries is very high, so like 99.8%. So we cover most of the women who delivers in the country. And this is how birth registry looks like on the interface. It's a digital platform. So for each of the pregnancy, we get each line of the antenatal care visit. So it's fully electronic, integrated with e-health platform, and because in Georgia all citizens have personal IDs, there is a possibility to merge it with other health registries. So it covers 99.8% of births in the country, even though women are not attending, 5% of women are not attending antenatal care, they are delivering at the hospital base. Yeah, and right now in birth registry we have over 400,000 entries for births. The system has some kind of an interoperability. The birth registry is linked with the Ministry of Justice database, so some of the demographic information is automatically generated once the pregnancy is registered. It's also linked with the immunization registry, with hepatitis C electronic system, and National Health Agency of Georgia. But we also have some other health registries which are not linked with the birth registry, and this is kind of a gap for us. So with the support from the Alliance for Health Policy and Systems Research, we conducted the mixed method study with the aim of to look at how does birth registry implementation in Georgia improve continuity of information for care and early detection of diseases during pregnancy by antenatal care providers. We collected data from doctors, data entry personnel, stakeholders, and people working with the financial reimbursement process. What we saw was that on the patient level, there was improved follow-up and accessible data on previous pregnancies, and also abortions, because it also registers the abortions, even though it's underreported. The financing process got easier for antenatal care provider. Now, since the birth registry is implemented, the doctors have a possibility to look back in the records and see how was the previous pregnancy or previous abortion, and that provides reliable and valid information on that. And for the system level, we have individual level data for pregnant and newborns, which we did not have before, and we have a possibility for research and to calculate the indicators based on individual level data. As I have mentioned, the reimbursement process from the state health program got easier. Now, through the system, doctor can request for the financing of the pregnancy, and women does not have to go physically there to get pregnancy financed. So every woman has a possibility to get 8 visits, like WHO recommends, free from the government. What we also saw was that GBR improved effectiveness and monitoring of pregnant women's health, and it also improved accessibility of the information in time and space. However, we have some challenges. This research found that the privacy protection related issues like SMS codes, which are needed to get, if woman changes the healthcare provider, they have to enter the SMS code, which is registered for the women's phone number, to register the lab results and to kind of continue the monitoring of the pregnancy. And we found that that caused quite a lot of frustration, and it was annoying for both ANC personnel and for the patients. We also saw that there was an equitable access to information to help ANC providers, and especially for the minorities. There is one region in Georgia where minorities, ethnic minorities are living, and from these regions, the doctors reported that it was very helpful for them to have a possibility to review the previous pregnancy due to the language barriers. So what we saw, just to sum up, was that digital health intervention as birth registry, that provides better coordination between ANC providers across pregnancy, because it's also quite normal practice in Georgia to have to change ANC provider during pregnancy, and primarily data for statistical reporting and reviewing previous pregnancy outcomes became available. However, data entry process is time consuming, and doctors still need to enter data in many multiple systems, and of course it has an impact on data quality. So the birth registry, to sum up, is a medical birth registry comprised of an interactive database and architecture. It's governed by the policy and regulations, and it's usually used by leaders to plan, resource, and manage systems that support health personnel to provide services for people so that the health is improved. We just want to acknowledge from our team, the Health Policy and Systems Research Alliance, because that without our support we could not manage to finish this work. Thank you.
Thank you so much, Dr. Tinatin. It was a wonderful presentation, and also a very interesting perspective of a national digital tool that is backed by laws, but then also we see the challenges at the healthcare level. Now, I'd like to invite Emma Efuadi Maro. She is a researcher in digital health and health systems, and also a monitoring and evaluation officer at the Ghana Health Service. She will present their study on 2 health management systems in Ghana. Please.
Hello, everybody. Good morning. So, Ghana, we did our study in data-driven decision-making by primary healthcare managers. I wanted to see how they were using this to make decisions. So by way of introduction, the Ghanaian system operates 2 different digital health interventions. We have the Digital Health Information Management System, that's shortened DIMS, and we also have the Light Wave Health Information Management System. The Digital Health Information Management System was introduced in 2012, and it just speaks to aggregate data. So people report in repositories at the facility level, and then they send that composite data into a repository that sits at the national level. And this one is strictly owned by the Ghana Health Service. And the Ghana Health Service is actually the largest implementing agency within the Ministry of Health. But the LIMS, that's the Light Wave Health Information Management System, was operational in 2017. And that is basically an electronic health record system, medical record system in other countries. And that is just hosted at the Ministry of Health. So we have these 2 systems that are working together, and we wanted to find out how the use of these 2 systems by primary healthcare managers actually supports what they do at the workplace. Basically, that was what our study was about. So by way of objectives, we just wanted to see the contribution of these 2 systems in our healthcare by these managers, whether it's actually the data or the information they are getting is of that quality, because it's 2 systems, so of course, there should be a high level of quality that we expect. And whether these systems are actually interoperable and what issues surround the interoperability. And finally, to look at the challenges that the primary healthcare managers are facing. So we approached it with a mixed method approach or design. We did our study in Accra, that's the capital of Ghana, and we used primary healthcare managers, 125 of them, 10 district hospitals, 1 regional hospital. And by way of analysis, we just did a descriptive statistics and that of a thematic content analysis. We sought ethics from the Ghana Health Service as well, and we ensured that there was some level of quality assurance. So our shared experiences, that's why we're all here, to know what actually happened. We found out from our study that actually primary healthcare managers were using these digital systems for a lot of things. But one of the things that actually stood out was to identify service gaps, because they were able to use either of these systems or even together to identify service gaps. Again, they talked about some challenges that the systems was helping them to be able to identify, and also for them to be able to know how to allocate their resources. So we had some people talk about this way, that they are able to use it to monitor the wards as managers to see what actually pertains there and what actually happens there. And some of them are just able to use it to do supervision aside monitoring. But then there were some system challenges that our study also found out. That ideally, these systems are 2 and they are used in one healthcare system, but they do not communicate at all. They do not have any link to each other. So that was one of the systems challenges that we found, and we sought to find out why and how that could be dealt with. Again, the primary healthcare managers were manually actually putting the data into the repository. Something that we expected that the digital system was able to make easier for people, but they had to actually collate and manually enter into the system. So somebody said that we have to take data from the LIMS, that's the electronic health record system, and then do some manual calculations and entry, and that they felt was more of a challenge. So the process was actually bringing a lot of duplication, because if I collate the data and I'm not available to enter, somebody else has to do that. And so there were issues of duplication that was being seen. All right, and then, so with all these said, then there's a need for some form of interoperability, and I believe that this is seen in most countries where systems are working in silos, and we actually found the same in our system. So someone said the reason why I shouldn't bother myself doing manual entries all the time at the end of the month, it's that it could be that the system is designed in such a way that the form in the DIMS and the content in terms of data elements are the same ones. So, I mean, if they have this kind of mindset, you can tell some of the attitude that would really come to play when they have to do these manual entries. And that's what our study was more about. So in terms of challenges that we found in our study, we saw data security issues. We also saw human resource challenges and technological challenges. By security, because they have to enter the system with a password, some of them even had to use personal devices. Imagine the infrastructure is not enough and they have to enter into a system. They rather prefer to use their own tablet or laptop to do the data entry. And so there were some audit lapses that we found in our study. Well, for human resource, you know, some people are born before computers. So the older nurses and primary healthcare managers were struggling with some of these interventions because the interface was a bit different, or they were not too familiar because they were actually born before computers. So we also saw that in our study. And with the issue of high staff turnover was also an issue, because you know now a lot of people are migrating to foreign countries. So that increased the workload for healthcare providers, because they had to do all of this alongside the primary work that they had to do. So it actually increased their workload. And of course, the technical skill deficit, people don't really know how to use them. It looks like it's in the books, but that is actually what is pertaining on the ground. For technological network issues, we have at this part of the world, so these things are common: power issues and inadequate devices for digital technology. So our key highlights from our study is that we just realized that there's a shortfall in the use of these two innovations. They are great technologies, but there are some shortfalls that we need to look at. But the DIMS is actually used for reporting. Most of the time they use it to report, but the issue of the manual entry was a key highlight for us, because we wanted to avoid data inaccuracies. The heavy workload that I've talked about with the staff shortages was also contributing to some of the data inaccuracies. And I don't think we want to invest into digital interventions and still be reporting some inaccuracies. There's a gap there. But the electronic health record, that is the LIMS, is actually preferred by the primary healthcare managers because it really has a very user-friendly interface. So by way of recommendations, we felt that we should improve the infrastructure and services for the digital health interventions. It's not enough to just introduce interventions without actually improving the infrastructure for them to use it adequately. And if possible, they should just adopt one health intervention that speaks to each other so that it makes it easier for primary healthcare managers to use it. And of course, the digital literacy. We need a lot of learnings here. It has come to stay, but there's a lot of learning that we have to do. And why don't we just focus on interoperability issues? Because these fragmentations actually distort the data that we struggle to collate and document. And training and capacity building of primary healthcare managers was also recommended. We want to acknowledge these organizations for their support. It's been a wonderful journey, and we want to acknowledge them. Thanks for listening.
Thank you, Emma. That was wonderful. Very good reflections. And we see two parallel systems and the challenges that brings to healthcare workers. That's the reality they have to manage because these systems are not speaking to each other. So now, as our third presentation, I want to introduce Mongal Singh Gurung. He is the head of health information and research at the Ministry of Health of Ghana, and he will present insights on the Bhutan vaccine system.
Good morning, and it's an honor for us to, for me particularly, to present about the insight and the lessons that we have learned from our studies. The study was about enhancing health governance and citizen empowerment through Bhutan vaccine system. So before I go into the lessons and into the study, I would like to quickly take a few seconds in explaining the study setting for some of the audience. So Bhutan is nestled in the eastern Himalaya between China and India, and with a population of little over 700,000. And the healthcare services are free at point of delivery in Bhutan, and it's delivered through the 3-tiered system. And one important thing about Bhutan health system is we don't have private providers in the country. Now, when you talk about the digital health intervention in the country, like any other country in the room and beyond, Bhutan also want to leverage the potential and opportunity given by the digital health intervention. So we have policies, we have strategies in place, and Bhutan have embarked and started many systems. And particularly in COVID-19, Bhutan used many digital health solutions, including the Bhutan vaccine system. So Bhutan vaccine system was developed for COVID-19 vaccination, and later 2 other vaccines were added in it, HPV vaccines and the flu vaccines. And of course, provider could provide the service, record, do anything, and the people, when it comes to people, they can register, they can view their record, certificate, report AEFI. So these are all the potential in the Bhutan vaccine system. As a result, what happened was the COVID-19 vaccination coverage was among the eligible population, 99.3% of the eligible population in Bhutan, which is 5 years and above, received COVID-19 vaccination. So this was the Bhutan vaccine system played a crucial role, because the people everywhere from the sub-district, at the national level, everywhere people were doing a real-time monitoring of the coverage at various levels. And the other factor was the leadership also played, so I would like to acknowledge. And in the study, what we actually tried to do was we wanted to investigate the impact of Bhutan vaccine system on this high vaccination coverage and the empowerment of citizens, and it was a mixed method study. The lesson learned, of course, Bhutan vaccine at the overall level, Bhutan vaccine system provided the hands-on experience for the first time to all stakeholders, from the field level to the highest level. Everybody knew what it means and what are the challenges, what are the potential of using a digital health solution. And also it provided a valuable insights for electronic patient information system. Now, this electronic patient information system is, in a way, is an ecosystem of system. From the registry till you name it, you think all the system that is required for the patient care is there. All LIS system, the PAC system, everything is integrated as a sub-module within this system. So it provided a very valuable lessons, the Bhutan vaccine system. And when you talk in the context of patients and the community, it provided platform for them to provide digital consent, which is very difficult when it comes to face-to-face consent, particularly in our sort of a setting. And if you look at what the participants have to say from the field, I quote, "We no longer need to spend time or money visiting health facility for certificate. We can download them ourselves." The last part is very interesting in terms of empowerment. The government should do the same for lab reports. They are already getting empowered to demand services and what the government should do. So this is very interesting, and I want to highlight. And in terms of the primary healthcare provider, of course, the digital reporting potential was underutilized. As our key finding was data export was not utilized or not involved during the development of this. Ideally, when you develop digital health solution, there are 2 groups, IT themselves and the domain expert, medical doctor. But there are third party which are often ignored. So if you have to fully utilize this data reporting potential of the digital health solution, this data export has to be core team in the thing. That is one of the key findings from this lesson learned from this study. And of course, there were some double reporting, and the one more important lesson that I would like to highlight is about the preference for a single system rather than having to toggle with multiple systems. One patient works, because in the primary healthcare setting, it's a lone health care provider. So one patient walks in, you log into one system. Another walks in, you log into another system. They said this is not how they prefer. So they want everything to be one system. Therefore, this recommendation is provided, and most likely the other 2 vaccines will also go to the EP system. And of course, there are many other lessons learned, particularly on the key enabler for successful DHI. of course, we have also heard from the Ghana devices. Our end user, the community health worker, in the first place, don't have access to the reliable or good usable laptops and the tablet. And one thing that get compromised while designing any digital health solution is compromise on provision of these services. So what the health worker community people are saying is, give us good laptops. You want us to implement the system, but we don't have access. And people are, the government and the development partner also are saying, you compromise on that. We'll support for the system development, but not for the devices. But at the end, so entire thing is failing. So what the community health worker are demanding is, or expecting us is, provide them, if don't compromise on this thing, if you are serious about digital health solutions. And of course, there are issues of power backup, internet issues, policy for data protection, data utilization, those are also there. And of course, what did the Bhutan Health, this particular study did was, it informed the digital health strategy 2025 and also the maturity assessment. So Bhutan is in 3, so the study finding were useful in all those things. And the one thing that I would like to really highlight is on Bhutan vaccine system. Our study made it possible for Bhutan to make it a first country to do nationwide rollout of ICD-11. So that was one of the direct impact of this study. And at the end, I would like to thank the Alliance for giving us this opportunity. And I just want to reiterate what Lorena was trying to say. In the study, when the grant proposal was called, there was it was mandatory to have a policy maker as well as an academic in the team. And that did a magic in terms of translating the research finding into policies and actions in Bhutan. So I would like to really applaud. So anybody, if you are thinking that you want to really bring and translate your research finding into policy and actions and buy-in from the policy maker, try to look for some mid-level policy maker. I belong to that category. So because the high level, they don't have time. So it's better you target some mid-level officer, so in order to translate the research finding. With this, thank you very much.
Thank you, Mongol. I must declare I did not ask him to say that, but thank you for that comment. Really appreciate the very good perspective, and that's what we want to bring here, the value of having this co-production approach. And also, like, we are already seeing the contrast between some of the countries from private sector to no private sector at all. Also, the shift in expectations in citizens with digital technology. So all of that is giving us a good start for the panel discussion. But before that, I just want to show you 2 slides, because these are the summaries from the multi-country research program. You just heard about the 3 of the projects, but we also had others. And so through our projects, we saw that there were benefits, as you saw here. Really, these digital interventions improve decision-making for healthcare providers, and that represented a good health outcome. In case of Bhutan, but also in the case of Indonesia, we saw improved vaccination coverage. We also had improved tracking and monitoring of people and patients. It also improved the availability and accuracy and completeness of data, which then translated into better surveillance, better planning, better resource allocation. And third, we also saw the positive impact in communities through these examples, and one of them is Bhutan, how that increased empowerment across communities. However, we also saw the unintended consequences of the integration of these digital interventions in different settings. And these were some of them mentioned through these conversations. So fragmentation, healthcare workload, lack of planning. So in some settings, these digital tools were designed to be used by some and specific people, and they were trained to use it, but the practicality is that when you go and assess who are using it, is you see an adaptation of the system, either because there's not enough workforce, either because they don't have time. So really there was an adaptation on how that was happening, that integration was happening at the level of the PhDs. And so what I really want to now go is to our panel discussions, because really these are system issues. These are not technological issues. We see that as a problem for health systems. So with that, now I want my speakers to join the panel, and then also welcome Rubaiyat Khan from Endless Health to be part of this panel discussion. So a big applause, please. Okay, so I'll sit. So thank you for the wonderful presentation, Tina Tina. I'll first go to you. I was wondering, you talked about a little bit during your presentation, you saw how the GBR really brought value to the system, and but then also it made it challenging for users, for providers to really access because of these layers with data privacy and quality. So I was wondering for you, really, what was your perspective about how governments and decision makers can balance this tension between data privacy, data quality, and really the usability for primary healthcare providers, for users? Over to you.
Thank you for this question. Actually, the privacy protection related issue has been reported a lot from our private healthcare providers. And one of the biggest things when we were discussing about the results was that, and that has been actually discussed about it yesterday as well, the key is the communication. And the first thing is that we need to understand from the government level that it's, we need to make them understand that it's important. For instance, like 9 years ago when GBR started, we did not have that many privacy protection related regulations, but it's getting more and more importance, and the implementations in this field are getting more and more. So first thing is that the system has to be flexible, just to adjust to the differences or the new regulations easily, but also we need to talk to the women and also the pregnant women in our case, but in general the population and the community health centers and private and the healthcare providers, that it is something doing for their own sake. It's not just only for system, and the privacy protection is important for the population in the first place. And I think that the lack of communication was the key factor why it caused a lot of frustration, because we cannot remove regulations about privacy protection. It's something really important. But also I think that specifically for birth registry, and it could be used for many other digital health systems, is that I can give you an example. For instance, the antenatal care visit can only be editable within 24 hours once it is registered. So after that, doctor has to get SMS code from the women to edit information there. So if we could make it like longer, a bit more hours than 24, it would be easier for doctors to edit information, for instance, register laboratory test results and write the actual values instead of the faked values, which would increase data quality as well.
Thank you so much. I really like your point, and you mentioned it about the flexibility of the systems, how they should be flexible. And I just like to reflect that health systems are dynamic. They are not static. And sometimes what we design, what we think would work, is very static. So having that mentality and that consideration up front really it can help better integrate these interventions at health systems. Now, I'd like to come to you, Emma. You gave a wonderful presentation about 2 different systems being integrated and being used by the same people. And these were designed by two different entities. So I wanted to ask if you could reflect a little bit about the historical, the institutional, the political context, and how these reflects, and how can we do better in considering these, because at the end there are powers, there are relationships behind the implementation of these digital interventions in countries.
Thank you for the question. So like I said, in Ghana, we have the Ministry of Health, we have the Ghana Health Service. The Ministry of Health is the policy-making body, and the Ghana Health Service is the implementing body. And these two bodies are at the top of the healthcare system. So we have two different digital interventions in one country being used by one healthcare delivery system. Already, that's a lot. But then these historical perspectives does not just make it easier for healthcare professionals to use the technology, because the question is that there are power dynamics that are playing in this perspective. So if you're using the digital intervention, you have a challenge. Who do you report to? If, for instance, if the problem is coming from the Ministry of Health, but you are at the implementing agency, what is the chain of command? Okay, so already that basic intervention that is supposed to make things a bit easier is a bit conflicting. And so that's what our studies sought to find. And we ask ourselves that when power is not balanced, systems remain very fragmented. Not that the tool or the intervention is not helping, but then because the power is not balanced, it's a bit fragmented. And so these are the perspectives that we looked at with our study. And we think that in all this, using a health policy and systems approach, what is important is that we appreciate that both of these systems are very necessary. We need the DIMS, we need the LIMS in our healthcare delivery system. But if they should speak to each other, if we could report on both, or if we could use both for our decision making at the same time, it will make it a lot easier. And that's what we think, that as we are here discussing these discourses, these are the things that we have to consider. Thank you.
Thank you, Emma. Yes, and thank you for the frankness. These are very sensitive and difficult aspects, and so thank you so much for bringing that to this discussion. Now I'd like to come to you, Mongal. You showed a very interesting example where from the beginning there's a national strategy on digital health. You've been part of it yourself. You're a policymaker. You're now being part of the National Digital Health Strategy for 2025 and over. And that's been a very successful view on what you presented. So I wanted to ask if you could reflect a little bit about the leadership and the political will, and how that helps and contributes to the sustainability of digital interventions in countries.
Thank you. That's a very good question. And I think everybody acknowledges, and if you look at all the strategy, global, international strategy, of course in the health, building blocks of the health system, governments and leadership comes. Similarly in the ITU, WHO, that 7 enabling building blocks, the underlying factor is the leadership. So in Bhutanese case, and in one of the slides, I deliberately chose to keep that slide to acknowledge the role of leadership in successful implementation of the system itself, as well as the vaccination uptake by the community. So the leadership plays a fundamental role. Therefore, people who are designing this system, any digital health intervention, you will have to, everybody knows and literature acknowledges this, but we will have to involve them while implementing this. In Bhutan case, people, because they are not supposed to go and implement and use the system, what are leaders supposed to do? We should make a dashboard where they can do real-time monitoring. And that was exactly what Bhutan vaccine system did. So the Prime Minister, the local government leader, the health facility manager, everybody was doing a real-time monitoring of the vaccination. So they could do a real-time intervention. So if you understand this, I think this is going to be a crucial factor. Thank you.
Thank you, Bhutan, and thank you, Mongal. That was excellent, and really, I think we can all learn from what you are saying and try to bring people to the table, but particularly policymakers. They are key. We know that. We've been discussing these many times. But how do we bring them? And a practical example is really make them part from the beginning in many of the conversations we have. And he gave us a key message during his conversation, trying to reach the people who can give us the time. The engaging needs time, and sometimes policymakers don't have enough time. So who do we reach out? It's also something we should be considering. Now, I like to ask Rubaiyat, you are an entrepreneur. You've been working with many ministries of health and supporting the many governments in their digital transitions. And you've been part of these for the last 15 years. So you saw the first transition in the 2000s, 2010s. And I wondered, what have we learned from there? And now that we are in the era of AI, what are we doing to learn from those lessons and don't fail? Thanks.
Hi. Thank you, Lorena. I think a lot of the points that I was going to make has already been covered by the panelists and the presentations, because I think the examples that we saw being presented today are all good examples of how digital health transformation should be done, where you build the foundational building blocks, the birth registries, the basic infrastructure and architecture that everything else relies on, right? I'm sure the birth registry that our colleague from Georgia showed is not just useful for the government, it's useful for many other private players or other providers out there. So those are the building blocks that everybody else kind of builds on. So that was, I think, the first major lesson from the digital health era, that we started building standalone tools. We did not see any private sector innovations here today in today's presentation. But of course, there was a plethora of private sector innovations in digital health that were tackling specific problems, but were isolated from each other. They're not connected to each other or with national systems. And so people did not have continuity of care. Things became really fragmented. We could not measure outcomes. A lot of those challenges were kind of a direct result of the fragmentation of the digital health ecosystem, which is why, and of course there was a lot of duplication of resources as well. We were building the same things over and over again. So in the second part of the digital health era, maybe starting around 2017, 2018, we started learning that establishing those standards and architectures, in the previous panel we spoke about the full stack approach, where we think about the standards, architectures, and reusable components, which can be the building blocks that everybody else builds on. And I think that provides the kind of flexibility that we were talking about. When you have the architectures and the modules in place, you can put them together in different ways, in different contexts, based on the local realities and needs. And they don't need to be monolithic things that you can't then change, right? If you follow a standard, you can easily replace that tool with something else, or integrate two different tools much more easily because they are following the same standard and architecture. So those are the kinds of lessons that we learned in the second half, and we're making some progress. I think we're still far away though. I think the countries represented here are probably more advanced in terms of their governance and infrastructure, but there are many other countries that are actually further behind. I also wanted to reflect that what was being mentioned about the role of leadership and culture. I think we need to acknowledge that technology is probably less than 20% of the problem. There are enough technologies out there. It is the right vision, leadership, the stewardship, many governments don't even think about the different roles that different providers, including private sector, plays in care delivery. So it's really important that governments take their role in being stewards of the overall health system seriously and set the right visions for their countries, which then allows for some of these things to flourish and take root. And there's, of course, role for conducive financing as well. We saw how USAID's fragmented funding and other fragmented funding infrastructures caused the fragmentation in some of our countries. And the final thing that I'll probably mention, there's many things that we could probably take away from the first phase. Another one is the shiny object syndrome, as I call it, right? There's a new technology. In that era, it was mobile phones. Now it's AI. You run after that as the hammer in search of a nail, and unfortunately, you don't think about what are the core health systems challenges and problems we're trying to solve, and how might technology help solve them. So there is, I think we're repeating that mistake now again. With AI, we're bolting on chatbots on everything, but there is more foundational thinking that needs to be done. And I think the Alliance and others like the Alliance and the experts sitting on this panel have a role to think about what are the challenges that we're trying to solve within our health systems and create the right environments where technology can come in and help solve those challenges. So I think, yeah, there's a lot of things that could be said, but just to say that in the AI era, I think we are learning from some of the mistakes, but not all of them. And we need to remember that if you digitize broken systems, you'll end up with a broken digital system, right? So it's really important that we fix the systems first and then think about how to digitize it. Thank you.
Thank you, Rubaiyat. Wonderful. And also, I like that you brought in the role of the private sector. More and more, we need to engage them and also see the incentives and try to find ways to engage them, because they can have a positive interaction and bring benefits. But we need to also think, what are they gaining? What are we gaining from that interaction? And try, like, this is about power and relationships as well. So that consideration and changing what we need to do for now this new era of AI, it's really important. So now I want to go back to Mongal and Tinetin, because you briefly mentioned, but I know your studies very well, and they both had an equity lens. We saw in not only your studies but others that some populations were excluded, marginalized people, people with low digital literacy, low access to technologies. And I wonder if you could reflect a little bit and think and tell us how can governments really ensure that digital tools do not leave that people behind? So.
Thank you. That's very, again, fundamental, very important question. And this debate is there, and this is a fact. There will be, particularly in the lower and middle income country, this digital divide because of the illiteracy as well as the digital illiteracy is always there. So in Bhutanese case, what we were mindful about this repercussion of the loopholes. So what the government tried to do was, we fielded in volunteers to help illiterate to register and assist the health worker during the vaccination time. And similarly, to enable our illiterate people to access those certificates and all for travel sakes, we have set up a community center where anybody could go and get those certificates. So this, when we design, in short, we will have to think of all stakeholders into consideration. Thank you.
Thank you for this question. For Georgia, since it's mandatory by law, in most of the settings in ANC clinics and maternity homes, the internet access and computers are in place. Of course, we got reports about some unstable technical support from some of the rural areas. But I have to mention about vulnerability in general, that GBR actually improved it in some ways. Like I mentioned during the presentation, for those who are working for, those doctors who are working for the minorities and ethnic populations, most of the women are not speaking in Georgian Georgian, and they had a problem with a language barrier when communicating with the doctors. But through the birth registry, now doctor can revise the previous medical history based on the electronic records instead of asking a lot of questions with the women. So it actually improved in a way. And I have to also mention that there are this 5% of women who are not attending at least one ANC during pregnancy that could also be targeted from the government and prioritized to promote antenatal care through birth registry, because we have demographics and all predictors for these women in the system. Thank you.
Thank you so much for those comments and reflections, and the design, including in the design, and design for equity is super important in everything that we do. Now, I'd like to shift a little bit in the final part of this conversation to reflect a little bit on HPSR. Emma, you came to this project as an implementer, as part of the Ghana Health Service, and I wanted to ask for you, really, what did this participation on an HPSR project, on seeing how two systems were very fragmented in your country, and how that can be, how can HPSR can be used for the digital transformation of Ghana? We have a very strong community on HPSR there. There's a lot of political will to use digital technologies, and I wanted to have your reflections on these.
Thank you. That's a very good question. So, health policy and systems approach, there was a problem, and we just wanted to find a solution to the problem. And that's what health policy and systems research just looks at. So the question that we wanted to answer was, how are they using these two systems to work as primary healthcare managers, to make decisions, to plan, to forecast, and monitor and evaluate the work that they were doing? So we just believe that there is an existing culture of practice. There's a system that already exists within the healthcare facilities. And so how do we fit this intervention into an existing structure that will make it so easy to use, so easy to understand, and so easy to forecast and make decisions as primary healthcare workers? And that's the experience that we had using the health policy and systems approach. Because usually it's just a tool, data health is just a tool that people are just using. But if it doesn't fit into an already existing structure, it's quite difficult to make return on the investment. And that's the experience that we want to project, that one of the best ways is to use this approach, because it makes it very easy to fit it into an already existing structure. Thank you.
Thank you, Emma, and thank you to all our speakers. Unfortunately, we just run out of time. We don't have time for questions, but let me just close with a few reflections based on this discussion. And thank you so much for being here for this conversation. So yesterday, during one of the sessions, we heard from Dr. Ayub Mania from the Ministry of Health, how digitalization in Kenya is complex, how some of the digital interventions were planned and designed in Nairobi, but Kenya was not Nairobi. And also the challenges with devolution, because there's these relationship between the national and subnational states. So these are all systems and systems challenges. And as we heard here, digital transformation is not just a technology transformation, it's a systems transformation. We are seeing how these digital technologies and AI are shifting how citizens appreciate their health. They are getting empowered. They are asking for more services. It's shifting the roles of healthcare workers, AI too, that might change. What trainings do we need? It's reshaping also data flows, and so decision-making too. And all of these are questions that countries are having right now and been having for the last few years with digital. And this is where really HPSR can contribute, because it really considers these power relationships, the dynamics, how systems change, the actors that are part of the the conversation, that are part of the implementation of digital technologies. And this is exactly where we think at the Alliance that we can contribute doing HPSR, but also supporting countries to really conduct that research in a co-production approach that can really have impact on their health systems, strengthen their health systems, and strengthen and have better outcomes for people. So with that, I'd like to thank you all for your wonderful presentations, your insights, and also thank our audience and our funders. So thank you very much and enjoy the rest of the conference.